Welcome to Senadhipan Education Foundation once again. Education is the key to unlocking the world, a passport to freedom. We started this education activities way back in 2007, and it was started by releasing a brochure from our institute by Antonio Dongo, none other than who invented stapler hammer. We launched Senadhipan Education Foundation way back in 2012 by releasing a set of educational videos by Professor Sion Hansen, a world-renowned surgeon from Korea. Then we started having 6 months and 1 year fellowship programs around hands-on in basic and advanced laparoscopic surgeries, which were all on-site programs. We gave hands-on training. With the advent of COVID, we started the online programs, and the logo was released by none other than Professor Palanivelu himself. And then we started live surgeries in our online platform. The first live surgery was in April 2020. That was in LIR. Then we started a live program in YouTube channel. The first live surgery was Lab Ripples, which was telecasted in August 2020. The link was shared to members of Senadhipan Education Foundation. And then we started having live lectures with the world leaders. So we recently started laparoscopic programs, international fellowship programs in lab HPB surgery, lab colorectal surgery, and lab upper GI surgery, and also endoscopic programs with our speaker today. These are the visuals of the candidates who completed the SCF International Fellowship programs in Tokyo Medical University with Professor Nakakawa Yuchi. There we have 48 chapters worldwide of Senadhipan Education Foundation. These are the ambassadors of Senadhipan Education Foundation in different countries. We have presence in 100 countries and chapters in 48 countries, and we have collaboration with many international universities. Our vision is to disseminate skills and knowledge to all nook and corners of the globe for the benefit of the underprivileged society with the no geographical boundaries, with the zero financial motive, so that a wider spectrum of population is benefited. Today, we are blessed with the best chance of endoscopy worldwide. Dr. Rajesh Puri, who is the Vice Chairman of Medanta Institute of Digestive and Hepatobiliary Sciences, Gurgaon, India. And my friend, Dr.ASADUR JORGE. He is actually the President-elect of World Endoscopic Organization. He is actually our ambassador in Uruguay. So we are happy to have Professor Rajesh Puri. Welcome to Senadhipan Education Foundation, and Professor ASADUR, who is the ambassador of Senadhipan Education Foundation, President-elect World Endoscopic Organization, past president of Uruguayan Society of Gastroenterology, past president of Inter-American Society of Digestive Endoscopy. He is advisor to WHO also. To formally introduce them, I'll invite Dr. Anharur Rahman, who is Associate Professor of Surgery in HPB and GI Surgery in Bangladesh. So before concluding, I request all the participants to mute their mics. Some of the mics are not muted because of some technical issues. Please, 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 please mute your device. You will be allowed to unmute once the program is over. If possible, kindly acknowledge by renaming your device by yours. Participants logging from outside India are requested to reveal their identity in the chat box so that the host can identify them. Raise your hand if you want to intervene and to talk. Everybody will be given permission to unmute their mic if they want to speak in between. If you are on a portable device, please mute your audio and hide your video. next webinar is going to be in December 17th. That will be by Professor Miguel Ecusta, who is my friend, and actually he'll be talking on minimally invasive esophageal surgery. He is a veteran in that field. So before handing over the mic to Dr. Anhadur, any request for certificates should reach us within 2 days. We cannot entertain requests which are coming after 2 days because we will be finalizing our certificates in 48 hours. So we can give the request to senadhipan@gmail.com if you have completed 80% of the screen time of the total program. If it is not satisfied, we will not be getting a certificate. So with these words, I stop sharing my screen. I'll be giving to Dr. Anhadur for the introduction, official introduction of the speaker and the moderator. Welcome all of you to Senadhipan Education Foundation.
Thank you, sir. I am Dr. Anhar Rahman from Bangladesh, Assistant Professor of Surgery. And I am very much grateful to ACF and Baju, sir, that giving me opportunity to introduce our speaker and moderator. So I am just sharing my screen to the PowerPoint. Can you just everyone show my screen?
Yeah. We can see.
Okay. Okay, sir. I'm just starting the slide. So today is a very fantastic lecture on endohepatology, and we have the legends. Actually, two living legends are there in speakers and the moderator. Our speaker is Dr. Rajesh Puri, sir. Sir is the current Vice Chairman of Medanta Institute of Digestive and Hepatobiliary Sciences, Institute of Digestive and Hepatobiliary Sciences, Medanta, Gurgaon, Haryana, India. Sir is one of the renowned gastroenterologists in India. Sir is now currently Vice Chairman of Medanta Institute of Digestive and Hepatobiliary Sciences. Started his career there in 2009 up to present now. Actually, he is a very much skilled and specialist in upper GI endoscopy, colonoscopy, ERCP, endoscopy, and in therapeutic procedure like varicose sclerotherapy, varicose ligation, hemostasis, dilatation of esophageal strictures, carcinoma, PEG, nasojejunal tube insertion, sanguine tube insertion, therapeutic ultrasound, and third space endoscopy. He's very much interested in therapeutic endoscopic ultrasound and third space endoscopy. The career of Rajesh Puri sir started from the MBBS. He's passed his MBBS in first attempt in 1987 to 1994. His MBBS in SNM College, Jodhpur, University of Rajasthan. And he is a very good record that in MBBS time, distinction in forensic medicine. And then he MD General Medicine, first attempt in 1994 to 1997 at the same SNM College, Jodhpur, University of Rajasthan. Then he did his DNB in gastroenterology, and that time he was a gold medalist, August 1999 to 2001 in Sir Gangaram Hospital, New Delhi. Now he is now the previous he was in consultant in Department of Gastroenterology and Hepatology, Sir Gangaram Hospital. Previously starting from senior registered medicine, then senior registered, then consultant. Now he is in Vedanta Hospital. He has a lots of actually professional achievements and conferences. It's more than 170 events I have just found in the internet and records. It could not be told in a simple time, but there are something like key faculty in AIG IDMS 2023, which is held in Hyderabad, 27 to 20th October, and speaker was Endoscopy Ultrasound Summit in 2023 in Seoul, South Korea. There is he was key faculty of UPSG Con 8th October 2023, Lucknow, and many other events. He was the key faculty and key speaker of the conference. His scientific publications is above, just for what I search, is 88. It's nearly 100, and he has also society and NGO activities. He was the secretary of SGEI and teaching experience more than 13 years. And he is also the advanced teaching faculty and examiner of Diplomate of National Board Gastroenterology Exam Board. So thank you. This is the Rajesh Puri sir's career. Actually, it's very small slide, but it has a long career and bright career, sir, which I cannot tell you. It takes more time. It's very short. I'm telling. Now I'm now presenting moderator. Our moderator is Dr. George TCHEKMEDYIAN, sir. He is the chief of endoscopy department of Association of Spainalia, Montevideo, Uruguay. And now currently he is president-elect World Endoscopy Organization, vice chair International Committee, American Society of Gastrointestinal Endoscopy, and ambassador Senadhipan Education Foundation, Uruguay. Actually, Asadur sir is currently the director of Digestive Endoscopy Service in Association Española Uruguay, and we have already told he is the president-elect in WEO 2026 to 2028, adjunct professor of gastroenterology, faculty of medicine, Udela, site director, principles and practice of clinical research, Harvard Medical School, and he was also some social activities. He was Aurora Forum Goodwill Ambassador. He has a lots of expression. He's one of the living legend in the world right now. He was in Spanish Association, deputy endoscopist, head of digestive endoscopic service, vice chairman International Committee, American Society of Gastrointestinal Endoscopy, ASGEA is 2022 present. In World Endoscopic Organization, he was member of the committee of WEO Standard of Practice and Publication. It started in 2022 to present, and WEO News and Communication Committee. Now he is the president-elect of WEO. He was also in International Atomic Energy Agency. It was about 12 years, 10 months. He was in technical expert of that association and newsletter editor. He was president, I've already said, Inter-America Society of Digestive Endoscopy, site director, principles and practice of clinical research, Harvard Medical School. He was previously president of Society of Gastroenterology of Uruguay. It was about 2015 to 2017. General Secretary, Uruguayan Society of Digestive Endoscopy. And he was adjunct professor, Udela Faculty of Medicine Hospital, De Clinicas. Clinic chief, US University of Republic. He was fellow of Maria Clinic and University Hospital Complex. And his education, we know he started from Cardon Institute. Then he was University of La Verne, and he graduated gastroenterology doctor from University of the Republic. And he was postgraduate gastroenterology. His postdoc is from University of Republic. He has lots of projects, many more projects I found in the net, more than hundreds projects he has already completed. One of the important is principle and practice of clinical research, International Distance Learning Clinical Research Training Program, and his article is more than 100. And he was reviewer of lot of journals. He was reviewer of the British Biology of Radiology, Journal of Gastroenterology of Peru, and reviewer of Acta Gastroenterologica Latin America magazine. And his article is more than 100. He was also awarded. He was awarded from Medical College of Uruguay in December 2019. It is a vocational medical award granted by Colegio Medical University of Uruguay, and it was a very prestigious award that time. So thank you all. This is from my desk, but I found two living legends in our SA Foundation. Thank you all.
Thank you, Dr. Anher, for the presentation of our speaker and moderator. Thank you, Dr. Anher, once again. He is our ambassador in Bangladesh. Welcome all to Senadhipan Education once again. Now I hand over the mic to our moderator to conduct the proceedings. Professor TCHEKMEDYIAN.
Well, hello, everyone. Thank you, Professor Baiju. It's my honor and my pleasure being your ambassador here and also being moderating this activity today. Really is an extremely interesting topic. In fact, some days ago, I was talking with my good friend, Dr. Infante from Cuba, and she told me about how great it was for you to introduce this topic as the main issue of this webinar. It's an emerging field, the endohepatology, a lot of people is getting involved. But if we look backwards for just some years ago, no one talks about endopathology. In fact, it doesn't exist at all. So we are very glad here to have Professor Puri. Presentation has already been made, and we are going to, for sure, to enjoy this topic about endohepatology. So it's for those that don't are familiarized, is the diagnostic and therapeutic endoscopic tools for the management of patients with liver disease. So thank you again, and go ahead, Professor Puri.
Thank you.
Thank you. Can I share my screen?
Please.
Is my slides are visible?
Yeah, visible.
Yes.
So I would like to thank Professor Rahman for giving the introduction. A big thanks to Professor BaijuSenadhipan Education Foundation for giving this opportunity. This is my third appearance, and I love to be the part of this educational program, and will be very happy to talk on therapeutic endoscopy, especially endoscopic ultrasound or the third space endoscopy. It's an honor for me that Dr. ASADUR George from Paraguay, he is moderating the session. Is an honor for me. And I will be very happy if anybody has a question, you feel free to stop me in between, or you can ask me. One of the best thing of this Senadhipan Education Foundation, that you can speak for 1 hour. I think that is where you can speak from your heart. And today I'm going to talk endohepatology, integrating the endohepatology in the clinical practice, unveiling the new avenue for the patients. So what do you mean by endohepatology? The integration of endoscopy within the practice of hepatology is endohepatology. A decade before, endohepatology means doing the upper GI endoscopy, looking for the esophageal varices, looking for portal hypertensive gastropathy, looking for the fundal varix, and treating the esophageal and the fundal varix with an endoscopy. But if you look in the last 1 decade, there's a paradigm shift, and endohepatology has expanded the wings like an eagle, and it is not only for the assessment of varices, but also for the treatment of varices. EUS has emerged an important role for measuring the portal pressure gradient, EUS-guided liver biopsy, assessment of the liver parenchyma by the shear wave elastography. One of the very important thing which I want to highlight, because many of the audience will have a question. When we have percutaneous method, when we have a endoscopic method, when we have an interventional radiology, why do you need an endohepatology that is with the help of endoscopic ultrasound? So if you see the timeline curve, the traditional method started more than hundreds of years before, and they have matured enough with a long history of more than 50 years, 70 years, or more than 100 years. It has already matured. While endoscopic ultrasound is still in the infancy because it has a time period of 1 decade. So I will not say you can't compare the apple and orange, but to say, to introduce a new modality, and I'm very sure the large audience is from the surgical background. I distinctly remember when I was a fellow in gastroenterology, one of the finest GI surgeon, you may have heard his name, Dr. Simran Nandi from All India Institute of Science. And he used to say, big surgeon give the big incision. But the time changed. People started doing the laparoscopic surgery. People started doing the single port surgery. Now the era has moved toward the endoscopic surgery. So to say any new modality, it requires three important things. Is it safe? Do you have any safety data? Is it clinically effective as compared to traditional approach? Like we talk about the percutaneous liver biopsy. Is it safe? Is it clinically effective as compared to the percutaneous liver biopsy? Or what is an added benefit over the percutaneous liver biopsy or the EUS guided procedure, which I'm going to discuss for another 30 to 40 minutes. Any patient who was evaluated for the abnormal liver enzyme workup, and if he require a liver biopsy for the further intervention, for the diagnosis or for the staging. So what do? The traditionally people used to do the percutaneous liver biopsy, or if the patient is not fit for percutaneous liver biopsy, patient was subjected to the transjugular liver biopsy. The advantage of percutaneous liver biopsy, it is traditional, as I said, more than 100 years old, simple, inexpensive, can be even done in the ICU on the bedside. But the problem with the percutaneous route is it has a patient discomfort. You require to make the patient in the right lateral position for 4 hours. The complications are there in the form of bleeding, in the form of pain. You can only target the right lobe. You can only do the fewer passes. And if the patient is obese or patient has ascites, you cannot do. So if patient is obese or is ascites or coagulopathic, then what do? You subject the patient to the transjugular liver biopsy. And the advantage of transjugular liver biopsy is you can measure the hepatic venous pressure gradient simultaneously, can be done in coagulopathic patient, can be done in a patient who has ascites. But the problem with the transjugular liver biopsy, you require fluoroscopy, it is expensive, require a neck incision, patient discomfort, and it is costly. So when we talk about the endoscopic ultrasound-guided liver biopsy, let's look at the safety data. So this is a multi-center data from the 8 center, 110 patients, 19 G needle was used, and EUS-guided liver biopsy, you get in 98% of the percentage of the cases, you will get an adequate sample for pathological diagnosis, with a CPT score of 14 and the median tissue length of 38 millimeter. And out of 110 patients, 1 patient has a complication which was self-limiting in coagulopathic and thrombocytopenic patient, but was managed with the conservatively. So we have a safety data for endoscopic ultrasound. Now look at how it is comparable with the percutaneous liver biopsy or transjugular liver biopsy. This is the recently published meta-analysis of 5 studies, more than 200 patients. And this meta-analysis shows that there is no difference in the biopsy adequacy or adverse event when you do an endoscopic ultrasound-guided liver biopsy in comparison to percutaneous or transjugular. No difference between the specimen regarding both a complete portal tract and the longest length of the tissue. And compared to the transjugular liver biopsy, EUS liver biopsy shows no difference in the longest length of the piece and fewer CPT and the longest tissue specimen length. So this meta-analysis shows that EUS-guided liver biopsy give the adequate sample, give the adequate total portal tract, give the adequate tissue specimen length, and there is a no adverse event. Another meta-analysis published recently by Chandan et al. Again, 5 studies, more than 700 patients, and what they have shown that there was no difference between the percutaneous liver biopsy versus EUS liver biopsy, both in terms of diagnostic adequacy. Overall adverse event was not significantly different between percutaneous liver biopsy and EUS guided liver biopsy. And overall, higher CPT was more in the percutaneous liver biopsy. And if you look at the single center study, there are more than 7 studies which shows that EUS guided liver biopsy, the specimen length was more in comparison to percutaneous liver biopsy or in comparison to transjugular liver biopsy. EUS guided liver biopsy give the specimen length longer. The complete portal tracts are longer. So it shows that EUS is comparable in terms of diagnostic adequacy, in terms of adverse event, in terms of complete portal tract. Now the question comes, why EUS guided liver biopsy? The reason is that it is safe, and the biggest advantage is you are doing under real-time imaging. In real time, you are examining which area of the liver you are puncturing. You can avoid the bile duct, you can avoid the intervening vessels. It has a comparable complication rate, and overall adverse events were low. Clinically, it is effective. Give the adequate specimen length, give the normal CPT score, and in fact, more than the percutaneous liver biopsy in the single studies. And another important advantage is you can target both lobe, you can target the right lobe and the left lobe. What are the added benefit of EUS guided liver biopsy? Definitely people are going to ask the cost difference between the percutaneous liver biopsy versus EUS guided. So EUS guided liver biopsy is cheaper than the transjugular liver biopsy, but definitely costlier than. So you can incorporate if the patient require an EGD examination or he require an endoscopic ultrasound for pancreatobiliary region, then in the same setting, you can do the EUS guided liver biopsy and you can make the procedure cost effective. You can target both the lobe, both right and the left lobe. It is safe and provide tissue yield comparable to the transjugular and the percutaneous. Another important advantage is there is no pain. It can be done in the obese patient. It can be done in the patient who has a mild ascites. It is less expensive than transjugular liver biopsy, and there is no radiation exposure. So, in 2023, which patients is suitable for the EUS guided liver biopsy? Any patient who need a liver biopsy and also need EGD or require an endoscopic ultrasound for pancreatobiliary pathology. If patient is anxious, poor cooperation for the breath holding, you can give sedation. Patient will never be aware that this liver biopsy has been done, and you can target both the lobes. But the contraindication, as I said, if patient has a low platelet count, coagulopathy of more than 1.5 or the significant ascites, then you cannot do the EUS guided liver biopsy. Now, a few technical tips about the EUS guided liver biopsy. There are various studies. Look at the 2 important studies comparing the EUS guided FNA needle versus EUS guided biopsy needle. Always you will get a better result when you use the FNB needle. So the one message is, when you are planning to do the EUS guided liver biopsy, use the FNB needle, not FNA needle. Second question comes, which gauge needle? If you are attending the conference, people talk, they are getting the good sample 22 with the 22G needle also. But if you look at the studies, what the data shows, the 19G needle give the better specimen length, longer specimen length, and chances of the breakage of the tissue is less. So the 19G FNB needle is the best. Now, in the market, various designs of the needles are available. We have a manganese needle, we have a reverse bevel or the forward bevel needle, we have a Francine needles, we have a Charcot needle. So Francine and the Charcot needles are the best needle. So there's a good amount of literature available. FNB needles are better, 19G needle, and the Francine design needle is better. Now, the question comes, will you apply suction? If you apply suction, is it a dry suction or the wet heparin suction? Again, the study shows that if you do a wet heparin suction, then it gives the better results. Another important technical point, How many passes? This is very important, and this is a recently published study shows that you do the 1 pass with the 3 actuation. I just want to tell what do you mean by 1 pass with 3 actuation, meaning that once you puncture the needle inside the liver, then you move the needle up to the liver capsule. Don't withdraw completely needle. Move the needle, then by using the big knob, you change the direction in the 3 different directions. That is called, you are puncturing the liver capsule once, but by changing the direction of the needle using the big knob, that is called as fanning technique, you can do the 3 passes. And make sure that before withdrawing the needle and before puncturing the needle, always use the Doppler to avoid the bleeding vessel. When you are withdrawing the needle and if you see a track, always wait for 30 seconds. The blood is going to coagulate in that tract. And even if you see a track, then you have to compromise the sample by reintroducing the stylet, that is called as blood patch technique. So, first of all, I will again re-revise 19G needle, FNB needle, Francine design needle, wet heparin suction. What do you mean by wet heparin suction? You remove the stylet before puncturing, prime the needle with the 1:100 dilution of the heparin, and take around 5 cc of the diluted heparin in the syringe. Apply the negative suction. Before puncturing, put a Doppler as shown in this video. So I put a Doppler, the 19G FNB needle. You puncture after applying the Doppler. Choose the area at least 5 to 7 centimeters from your transducer. Puncture from front till the capsule. And by changing the big wheel, you can change the direction. So always see the area where you can puncture 5 to 6 centimeters deeper and do the 1 puncture with the 3 actuation. And before removing the needle, apply the Doppler. You can see the blood column is moving. So it is better to wait for 30 seconds till this blood column disappears. If you find this blood column is not disappearing, change the direction of puncture again once. And now you see there is no column of the blood along with the needle, and then remove it. Once you remove, flush the material with the diluted heparin or with the saline into a Petri dish, and with the naked eye, you can see the white core tissue or the blood, and you can separate with the needle, and the white core tissue you can send for histopathological examination. Now, EUS guided portal pressure gradient, that is HVPG. You know the importance of HVPG because the severity of portal hypertension is associated with the increased risk of death. More than 10 or 12 millimeter of mercury, high risk of bleeding, and more than 20 millimeter or 25 millimeter of mercury, patient may require a TEPS procedure. So if patient has a high portal pressure, high risk of decompensation, and if you reduce the portal pressure by 20%, then you can reduce the chances of bleeding and chances of decompensation. Till now, people were doing the HVPG again, which is invasive, require a fluoroscopy, is costly. So if you look at the EUS guided, again 3 points. Is it safe? Is it clinically effective when compared to traditional approach? And what is the benefit over the percutaneous HVPG measurement? So look at this study. This is a proof of concept study in the animal model, first published in 2016 in the GI endoscopy. And in this study, what they did, they measured the EUS guided portal pressure simultaneously along with the transjugular venous pressure measurement. So in the animal model, they measure the portal pressure simultaneously, both transjugular route as well as EUS guided portal pressure measurement. And what the data shows, 34 manometry, point manometry data shows, it has a very good correlation when you compare the transjugular versus EUS guided. So it is safe and it is as accurate as you are measuring the transjugular route. The first human pilot study was published in 2018 after 2 years in 28 patients, 100% technical success, no adverse event. And there was an excellent correlation between the clinical parameter of portal hypertension, that is presence of varices, portal hypertensive gastropathy, and thrombocytopenia. Then another study in 2020, US-guided portal pressure gradient measurement in a patient of acute and subacute hepatic portal hypertension. And this was done in 12 patients. It was successful in 11 patients, no complication, no significant difference in the operation time. And this study shows there is a very good Pearson correlation coefficient, high degree of consistency between the US-guided portal pressure gradient measurement and HVPG. So it is safe, it is effective, and it is as good as transvenous portal venous pressure measurement. What is the added benefit of US-guided portal pressure measurement? That simultaneously you can evaluation of the varicose status, direct assessment of the portal venous pressure. This is one of the very important points, because in HVPG, you measure the indirect measure. Here you are directly measuring the portal venous pressure. In a patient who has a pre-sinusoidal cause of portal hypertension, where HVPG is not accurate, US-guided method is more accurate. It is useful for prognostication of the varicose risk in clinically significant portal hypertension, and it has a potential to supplement HVPG. While the limitation of HVPG, as I said, it is an indirect measurement, it is invasive, require ionizing radiation, inaccurate for the pre-sinusoidal portal hypertension, and risk of bleeding, AV fistula, and the bile leak is there. And one of the very important thing, as I said, in endohepatology, with the one scope, you can do the liver biopsy, you can tackle the portal pressure, you can measure the portal pressure gradient. How will you do? So this is a very good small device. You see the central image, a small nanomanometer made by the Cook company, which has a compressible tubing, and it is attached on the 25 gauge needle. What you have to do? From the just below the G junction, using the 25G needle, you identify the hepatic vein. Many of the time in a patient of chronic liver disease, these veins are very small because of the regenerating nodules of the liver. Then you can puncture the IVC also. Otherwise, better to puncture the hepatic vein, either a middle or the left. Another important thing which you should remember, you should always go transgastric, transhepatic, then puncture the vein rather than directly puncturing the vein. Because the veins are thin, the risk of bleeding may be there, and especially in the chronic liver disease patient are coagulopathic. So avoid puncturing the IVC directly. Always try to go through the hepatic parenchyma, because while withdrawing the needle, you can again put the Doppler and you can see the vascular signal. And the hepatic parenchyma prevent the bleeding from the puncture side. So what you have to do, as I said, first ensure that this manometer take up to a mid-axillary line, make it at the level of 0, puncture the middle hepatic vein, flush with the saline, again with the heparinized saline, 100 industrial unit per ml. And after 30 to 60 seconds, you see there is a pressure stabilized on the reading, and you take 3 readings, an average of 3 readings should be taken. Same, once you have taken into the middle hepatic vein, you puncture the umbilical portion of the portal vein. Again, you go transgastric, transhepatic into the portal vein. And before withdrawing, make sure that you should apply the Doppler. Puncturing through the liver parenchyma, as I said, the most important advantage is you are avoiding the risk of bleeding. Once you have taken the 3 stable reading, then the portal pressure gradient is mean portal venous pressure, which you have taken from the umbilical portion of the portal vein to the mean hepatic vein pressure. That is a portal pressure gradient. So this is one of the very good advantage of endoscopic ultrasound. And this equipment is available from the Cook company. Technique, as I said, use the linear echoendoscope, 25G needle, compact manometer from the Wilson Cook, and it has an associated non-compressible tubing which comes, and use the heparinized saline. Maintain and make a value of 0 at the level of mixed axillary line. Puncture the middle hepatic vein, as we discussed. Take 3 readings. Puncture the umbilicated portion. Take 3 readings. And when you divide when you subtract the mean portal pressure from the mean hepatic vein pressure, you will get the portal pressure gradient. Now, the role of endoscopic ultrasound in the portal hypertension. I think this is one of the very important area, and where we have a very good literature available. US is used for the assessment of the varices, for the confirmation of obliteration. It is useful for the therapy of esophageal varices, gastric varices, ectopic varices, and identification of choledochal varices, and experimental role for the tips. I'm going to restrict my talk especially for the gastric varices. Esophageal varices, the less data, but in my opinion, EUS will be very helpful, especially once you eradicate the esophageal varices. But from the small esophageal varices, if the patient has a recurrent bleed, you can take your endoscopic ultrasound, you can target the perforators from the periesophageal vein, and those varices which cannot be banded, or after the banding, those small varices left and the portal venous pressure is very high, you can definitely tackle with the help of endoscopic ultrasound. Before going to the main treatment of fundal varices, it is important, first of all, to know the type of fundal varices. This is a serine classification, GOV1, where the esophageal varices go on the lesser curvature along with the gastric varices. These patients should be tackled with the bending. You don't require endoscopic ultrasound-guided glue and coil, but definitely GOV2 or IGV1 and IGV2. These varices can very well tackle with the endoscopic ultrasound-guided glue and the coil. So as I said, endoscopic glue is the current standard of care, especially in the Asian countries. But when endoscopic glue failed, majority of these patients were subjected either to BRTO or to the tips. Now, I'm going to talk what is the place of endoscopic ultrasound. So this is a real clinical scenario, those who are doing the endoscopy. You see the fundal varix, a gush of blood, your entire vision is obscured. A patient has taken the food and he has a bleeding. When you take the scope in, a lot of food material is inside. You cannot see the fundus. You have to turn the patient on the right side, make the table hand head elevated, high risk of aspiration. Patient might have a sometimes severe bleeding, as you have shown in the video, and it obscures the vision. Another important problem with the endoscopy, you cannot target the perforators, and you cannot assess the adequacy of obliteration. Many of the time after the bleed, the endoscopic visibility of the fundal varix is small, and sometimes you may not be able to identify, or you may be able to identify, but the varix appear to be small. And the most important problem is risk of embolization and risk of incomplete obliteration with the endoscope is there. So to overcome this problem, like patient has taken the food or patient is torrentially bleeding, and you know that you inject the glue, you are not very sure that is the glue injected is sufficient or not. And especially when the patient has an ectopic varix, where there is a large shunt and you keep on injecting the glue keep on migrating into the systemic circulation and the varix remain patent. So endoscopic ultrasound guided, EUS guided coil and glue is possible. Now, first of all, I will like to say there are the two kinds of scope. There's a forward wing echoendoscope and the linear echoendoscope. You can choose either of the one. But definitely the forward wing echoendoscope is especially useful if there is a lesion in the first part of the duodenum or second part of the duodenum. Why it is important in the second part of the duodenum? Because when you take your therapeutic scope into the second part of the duodenum, it gets curved, it gets angled, and it is very difficult to take the 19G needle from the EUS scope. So ectopic varices in the second part of the duodenum or third part of the duodenum, the forward wing echo endoscope is the choice. Many of the time, you are not able to see the GOV2 varices, or patient has a large esophageal varices. You don't want to go through the transesophageal route where the forward wing echo endoscope is very helpful. And the other advantage, it has a large therapeutic channel of 4.2 millimeter. The only thing is optical vision is small, but it is easier to intubate even the patient who is actively bleeding. Now, which route? You have a transesophageal, or you can use the transgastric. The better to use the transesophageal because you are going through the crush of the diaphragm, your needle is more stable. But as I told you, if patient has a large esophageal varices, avoid using the transesophageal route. Try to go through the transgastric route because otherwise you are going to taunt the esophageal varices. If the esophageal varices are not large, it is always better to go through the transesophageal route. Your scope is straight. Your needle can see the fundus. You put the water into the fundus so you can visualize the fundal varix very nicely, and you are not puncturing the mucosa. You are going from the esophagus to the crush to the fundal varix directly rather than the transmucosal from the cardia or from the fundus of the stomach. Now, this is very important for you to understand. There are two kinds of glue available in the market. In the Asian countries, the N-butyl cyanoacrylate is available, while in the European countries, N-octyl cyanoacrylate glue is available. What is the difference between two? Butyl has a very rapid polymerization time, that is 4 to 5 seconds. EUS needle is long. So once you inject the glue through the EUS needle, there's a high risk that your needle is going to be blocked. And the problem is not that you are going to waste the needle. The problem is you may not be able to inject the glue inside the varix because it has a very rapid polymerization time. So what you can overcome this problem by adding the lipid oil. If you add the lipid oil into 1:1, again the polymerization time increases and you can slowly inject. The risk of blockage of the needle and risk of the incomplete obliteration of the varix will be less. If you have an N-octyl cyanoacrylate glue, which has a polymerization time of 15 to 20 seconds, then definitely there is no premature catheter plugging, low risk to the personnel. Because in the N-butyl, we have a habit of injecting very fast. So please make sure that either you use the lipid oil or try to avail the N-octyl cyanoacrylate glue. Now, one of the very important things which I want to highlight, before embarking on the procedure, patient should always go for a CT scan because you should look, if your endoscopic method fails, the patient is fit candidate for IR or not. Many of the time, patient has a child C cirrhosis, patient has a hepatocellular carcinoma, patient has a portal vein thrombosis. So it is important to know, to talk to the patient. So do a CT angio if possible. If patient is actively bleeding, I agree, you don't have a chance to do a CT scan. Because if you know reasonably the size of the varix, you should have a coil should be available in the various size. It is available from 2 millimeter to 20 millimeter. I'm going to talk how to choose the exact size of the coil and which needle you should use. Because the coils are, as I said, available in 2 to 20 millimeter. The coil, if you are using less than 10 millimeter, and the diameter of the coil, diameter means thickness of the coil I'm talking, if it is 0.08, then you can use the 22G needle. But if your coil is more than 10 millimeter in diameter, or the thickness of the coil is 0.035, then you cannot use the 22G needle. You always use the 19G needle. Just to clarify, because I have seen many people doing the mistake, many of the time you are using the 8 millimeter coil, but the coil thickness is 0.035. In that case also, you have to use the 19G because the lumen of the 22G needle cannot take 0.035. It can take 0.08. Same, the wire which is going through the needle, 0.03 wire can only go through the 19G needle. 0.08 guide wire can go through the 22G needle. So this is important. Before seeing the coil, before taking the needle, always look at the coil which is available in the market. What is the diameter of the coil? What is the thickness of the coil? And these coils are the metal alloy, and which has a synthetic woven fiber which is all around the coils. And these fibers entangle the glue when you inject, and that prevent the migration. So as look at in one of the video, the small coil was used. You see the size of the varix is around 1 centimeter, but 6 millimeter coil was used. And look, the coil has migrated and reached to the lung. So please, before using the coil, always measure the diameter of the varix and choose the coil 1.2 times or 20% larger than the size of the varix. People can ask, if the 2 centimeter varix is there, then the coil of more than 2 centimeter is not available. That is okay. But if the varix is 2 centimeter and you use 8 millimeter coil, you use 10 millimeter coil, the risk of embolization of the coil is very high. So the diameter of the coil should be 1.2 times larger than the diameter of the varix, number one. Number second, the coil you should choose, needle should be used according to the diameter of the coil. Another important thing, the length of the coil. The coils are available in the 7 centimeter or the 14 centimeter. If the coil is 7 centimeter, it makes 2 loops. If the coil is 14 centimeter, it takes 4 loops. So this is how you opt for the coil. This kind of the varix, that is called as carpeting, and especially seen in the splenic vein thrombosis, where not the endoscopic method nor the EUS method is good for endotherapy. It is better these patients should go for the interventional radiologist rather than trying endoscopic ultrasound guided. Now, EUS wise, what can you do? You can use the glue only, you can use the coil only, or you can use the coil followed by the glue. I'm going to tell the advantage. Either you do the endoscopic glue, but you are not sure about the obliteration, or sometimes you over-inject the glue and the risk of rupture of the varix leading to the extravasation of the glue is there. So you cannot target the perforator. But if you are only using the glue, especially in the small varix, try to puncture the target perforators. And second is, you can minimize the amount of glue, so risk of embolization will be less. You can use the coil alone, but the problem is each coil costs roughly around $1,500. So the number of coils going to require more. So it is always better, the concept given by Professor Ben Moller, that first use the coil, introduce 2 to 3 coils. Again, the question will come, how many coils? There's no literature to talk about how many coils. But yes, once you introduce 2 to 3 coils, you see the whirling of the blood start formation in the varix. That indicates that the blood flow in the varix is slower down. And once you see the blood flow in the varix is slower down, I think that is the minimum number of coils you require. And once you have injected the coils, you have to learn how to inject. That is important. Then followed by the glue injection, and tell your technician, always wear the goggle, keep the close the patient eyes, and you also wear the goggle. Sometimes the glue can spill and can damage the eyes of the technician or the performer or the patient. Look at the literature from the India, very good, from the PGI Chandigarh, as well as from the Dr. Sahaj Rathi from the PGI. Again, both has published a good amount of data. And look at the literature. We have compared the endoscopic glue injection versus EUS guided glue and coil. And that shows that number of sessions required with the EUS is less in comparison to endoscopy. Obliteration at 4 weeks was much higher, 93% in comparison to 56% in endoscopic group. Bleeding after the index procedure was 13% with the EUS while 40% with the endoscopic method. Reintervention with the EUS guided glue and coil is much less than in comparison to endoscopy. Number of sessions required for the complete obliteration was much lesser in comparison to endoscopy. Rebleeding rate was less, and the reintervention with the for the gastric varices are less in the EUS guided group. This is the recently published meta-analysis, 23 studies, more than 800 patients. It has shown that EUS-guided therapy demonstrate a clinical efficacy for the treatment of gastric varices in terms of complete obliteration, less recurrence, long-term lead bleeding is less, and superior to the endoscopic glue. And on subgroup analysis, EUS coil followed by the glue has a better outcome in comparison to EUS alone, either a coil or the glue or endoscopy. This is another paper from the P. Mohan published in Endoscopy 2020, and that shows that if you use the EUS glue, EUS coil by glue, and endoscopic glue, hemostasis is comparable, but the obliteration is better with the EUS. And among the EUS coil followed by the glue is better in comparison to EUS coil alone or the EUS glue alone. This is another paper published in Endoscopy which shows that the immediate varix disappearance was much better with the coil and glue in comparison to coil alone, and the varix reappearance was better when the EUS coil followed by the glue in comparison to coil alone. This is a network meta-analysis and systemic review comparing the radiology and endoscopy versus EUS guided, and this meta-analysis was a Sukra plot, and which shows that in terms of mortality, EUS coil and glue had a lowest probability of overall mortality, followed by the tips. So EUS is very efficacious, shown in the various randomized control trial. This is our paper we have published in the gut, which shows that EUS guided coil and glue is a one therapy to rule them all, to prevent the varicose bleed, as a rescue measure in actively bleeding varix, and as a salvage method where the IR or the endotherapy is not possible. So what are the benefit of EUS guided coil and glue over BRTO tips or direct endoscopy? Because in a patient who has a child C cirrhosis or ACLF patient with the portal vein thrombosis, or where the IR expertise are not available and they are more costly. You know that patient who has a portal vein thrombosis, ACLF, you cannot do the tips if the IR expertise are not available and the IR expertise are more costlier. Risk of embolization in the direct endoscopic method. Direct endoscopic method has a problem of obscuring the vision, cannot target the perforator, cannot assess the adequacy of obliteration. So this is one of the video. So before that, I will just like to highlight few points. Use the forward wing endoscope or use the therapeutic linear echo endoscope. Use 5% dextrose or distilled water. Avoid using the saline, because saline decreases the polymerization time. There is a rapid polymerization, risk of blockage of the needle is there. So when we are using, always use the 5% dextrose as a flushing agent or the distilled water. Remove the stylet, flush the needle with the 5% dextrose. Before applying the injection into the varix, first flush the needle, inject. After injection, make sure that you are inside the varix. And especially when you are dealing with the varix of 1 centimeter, sometimes you may not be in the varix, but the needle appears. So suck the blood. Don't afraid of sucking the blood into the syringe. Reflush with the 5% dextrose. Then introduce the coil. And once you introduce the coil, the needle column will contain the air. So please again suck the blood, flush with the 5% dextrose, then introduce the second coil, and then introduce the glue. So this is a real case. We have published the data of more than 100 patients, but this patient who came with the 2 times endoscopy failure, bleeding, and patient has a hepatocellular carcinoma with the portal vein thrombosis. And this is the large bunch of the varix. You look at here, more than 3 centimeter varix with the multiple daughter varix. You can see the outside endoscopic glue markers here. You introduce the saline into the fundus to better visualize. So the fundus is full with the saline. It's better. You see the varix, you see the shunt. Can you see the large shunt? Once you have focused the shunt, you have an option. Either puncture the perforators or inject the intramucosally. This is the perforator you can see. Loaded the 19G needle, puncture with the 19G needle. I make sure that my needle is inside. I'm sucking the blood, reintroduce the saline, and introduce the coil, measure the size of the varix, choose the size of the coil 1.2 times larger than the varix. Here the varix diameter was 2 centimeter. We are using the coil of 2 centimeter. I generally do my procedure in fluoroscopy to look for any embolization of the glue, or I'm using the lipid oil so you can see the glue, is it migrating or not. So 1 coil, 2 coil, and you can inject the glue. Can you see the fluoroscopically? Here the 1 coil. Again, very important, when the large varix is there, make sure that your coil should be in the distalmost portion. Because if you inject the coil proximally, you will have a lot of artifacts. And once you have a lot of artifacts, it is difficult to see below. And once you have introduced the glue and the coil, you see the varix is solidify, and after 2 weeks, the complete solidification, and you see the varix becomes small. So EUS guided glue and coil is very effective therapy and give the very good result, and it is reasonably cheaper in comparison to interventional radiology related procedure. Now, the last part of my talk is EUS guided shear wave elastography. I think we have a time, Professor Baiju.
No issues, you can continue.
Okay. So this is a new armamentarium EUS guided shear wave quantification. The term is use quantification, not the elastography. But I will just like to say what is elastography is modality used to visualize the elastic properties of the tissue. And elasticity is a tendency of the tissue to resist deformation with the applied force. An elastography method takes an advantage of change in the elasticity of the tissue resulting from the specific pathology, either by a cancer or by a fat or by the fibrosis. And that you can see that what is the nature of the lesion. The elastography is mainly of 2 types, the shear wave elastography and the strain elastography. Shear wave elastography is again of 2 types. Transient elastography, you have heard the name of FibroScan or the RFE. It can be done with the EUS or it can be done percutaneous. So with the EUS, you can do the transient elastography. Now, what are the limitations of the percutaneous elastography? A patient who is obese, a narrow intercostal space, if patient has inflammation in the liver, more fat, or right-sided heart failure, cholestasis or ascites, you cannot assess the ultrasound elastography. And transient elastography, as I said, obese patients, you all know about the FibroScan, patient with ascites, or it cannot give the 2D images, and the left lobe cannot be targeted with the transient elastography. But this is a very important paper, that is a transient elastography discordance. This is a small paper, but it's a very informative paper. This is a study of 82 patients where the liver biopsy was done and the FibroScan, that is vibration control transient elastography, was done within 1 month. And this study shows that the discordance in fibrosis, and what do you mean by discordance in fibrosis? That is on elastography that shows F3, F4 fibrosis, meaning that KPA value was around 11 to 12. But on liver biopsy, it shows stays 0 to 1 fibrosis. So on liver biopsy, there is no fibrosis, but FibroScan shows a fibrosis. Discordance in the steatosis, again, how to define? There's a moderate to severe, you know the cap value, moderate to severe steatosis on the transient elastography, but mild steatosis on the liver biopsy. Or there's no steatosis on the transient elastography, but you do a liver biopsy, it shows a significant steatosis. And this study has shown that 82 patient who underwent a liver biopsy and the FibroScan within 1 month, out of 82 patients, 40 patients, meaning that roughly around 50% of the patient has either there is a disparency of fibrosis or steatosis. 72% has a disparency of fibrosis, and 32% patient has a disparency of steatosis. And among them, those patients who are obese, patient with the NASH, or patient with the cholestasis shows a disparity in the fibrosis. Same patient who are obese, NASH, or the cholestasis shows a difference in the steatosis. So, all the patients with the advanced fibrosis and the cirrhosis on liver biopsy are appropriately diagnosed on transient elastography. That indicates that advanced fibrosis, it has a good sensitivity. But detection of the steatosis is less sensitive. Only 19% of the patient with the moderate to severe steatosis on biopsy are missed by transient elastography. And transient elastography overestimate the advanced fibrosis in 35% of the population. So the conclusion of this study was, although the transient elastography, that is a FibroScan, is a highly sensitive tool for liver fibrosis, but it is not specific because they have missed the fibrosis. Same. So liver biopsy still remain the gold standard for the fibrosis assessment. So what is the concept of EUS shear wave elastography? Look at the shear wave elastography. It measures the shear wave propagation of the wave like a ripple. When the water drops into a water, or you drop a small stone in the water, you see the ripple of the water. And this ripple, this is called a shear wave. And if you measure the velocity of these waves, this is very accurate for measurement of the fibrosis and the steatosis. What happened in the transient elastography? I will again run this video just to tell what happened in the here. This is called as transient elastography. This is called as shear wave quantification. So transient elastography, sound wave goes and the wave which return back is a transient elastography. While in the shear wave, the sound wave goes, it produces a ripple and you measure the velocity of the ripple. So there is no effect of the fat or the obesity or the intercostal spaces. So how to measure? This is a linear echoendoscope and it sends the push wave. And push wave produce a ripple. And with this ripple in a designated area, by the surge pulse, read it. And you measure the shear wave quantification into the meter per second. So this is the push wave, production of the ripple, and there's a surge pulse, and shear wave quantification provide an absolute value of tissue stiffness within the region of interest. So what is the region of interest which I'm going to talk? So what you do, you choose the area of interest that is around 30 to 45 degrees from the center. Don't just see just below the center of your transducer. Take 30 to 45 degrees on the outer side, less than 3 centimeters. Your area of interest should be less than 3 centimeters from your transducer. Don't keep it more than 3 centimeters. And width of the ROI, that is the region of interest, is generally 0.5 to 1.5 centimeters. And please avoid the dilated ducts, avoid the blood vessel, avoid the calcification, and avoid the pressure by the transducer of the echoendoscope. And make sure that there is a value of VN. You see on this my screen on the right side, VSN is written. That is called as reliability indicate. So with each reading, the confidence indicator of the VSN should be more than 50% when you are measuring the shear wave elastography of liver. And if you are measuring for the pancreas, especially for chronic pancreatitis, then this VSN value, you can see the VSN value on the bar chart on the right side. You see the VS, E, ATT, and VSN. This should be more than 60% for the pancreas, and take around 5 to 10 consecutive readings. So how you do? Choose the area of interest, which is 0.5 to 1.5 centimeter, less than 3 centimeter of the below the transducer. Take 35 to 40 degree from the center like this. You see here, this is the box of 0.5 to 1.5 centimeter. Take 30 to 45 centimeter from the center. You see the value appears here. Look for the VSN should be more than 50%, and you take around 10 readings. And mean of this reading will come, and that will show you the pKa value, the shear wave quantification. And that is an excellent method to know about the liver fibrosis. The most important advantage is you can take from the left lobe, you can take from the right lobe, and you can take from the spleen also. And you can take from the pancreas, especially for the patient of chronic pancreatitis. Avoid the blood vessels. You take the 10 readings. You see, this is a reading which comes, and you will get an average of these readings. And this newer equipment is only available with the EUME3 or the Aloka aerata. So this is a very good paper and recently published paper in clinical endoscopy, and they have said US elastography towards a virtual biopsy. What do you mean by virtual biopsy? They have shown that patient with the cirrhosis has a significantly increased liver fibrosis index in comparison to fatty liver and the normal. So if the LFI is 3.2 versus 1.7 versus less than 0.8, you can differentiate, are you dealing with the cirrhosis? Are you dealing with the fatty liver? Are you dealing with the cirrhosis? And it has a significant p-value. So EUS guided shear wave quantification is like towards a virtual biopsy. This is another recently published paper, was presented in the ASGE oral forum in DDW 2022. 44 patients, same session, they did the EUS guided shear wave elastography and liver biopsy. So another advantage, if you are doing a liver biopsy, you can do the shear wave elastography. There's no extra cost, only going to take 5 minutes extra. And this study shows that if you measure the EUS wave shear wave quantification or elastography of left lobe more than 15 pKa, and if you measure the elastography of spleen, which is more than 26.3 pKa, it has a highest operating characteristics for predicting the fibrosis of more than 3, with a high positive predictive value and very high negative predictive value. This is another important study published in GI endoscopy this year, and they compare the FibroScan, that is vibration controlled transient elastography versus EUS shear wave elastography. And what this study is very important, shows that there's no difference between the area under the curve in the EUS shear wave elastography and vibration controlled elastography. But the important thing is 8 patients where the vibration controlled transient elastography was not possible because of the ascites, because of the obesity, because of the narrow intercostal space. But EUS was successfully able to do it. So the two important messages, it is as accurate as vibration control, that is a FibroScan. And another advantage, those patients where the transient elastography cannot be done with the FibroScan, you can do with the EUS. So I always feel US is the one-stop shop. If patient, you can do the shear wave quantification, you can manage the varices, you can measure the portal venous pressure, you can do the liver biopsy. If there's a single SOL in the liver, you can take the US guided biopsy for the assessment, for the staging of the disease. So regarding the shear wave quantification, I think it has an advantage over the transient elastography in obese patient or a patient with a significant steatosis. US shear wave quantification correlate with the liver histology, safe, reliable, and shear wave elastography is an alternative diagnostic tool and role in the lymph node, adrenal, and the submucosal need further education. What are the future which is going to come soon? US guided contrast enhanced US, I think, is already proven. Portal venous sampling, the data is emerging. Artificial intelligence, lesion targeted chemoembolization in the patient of HCC, US guided photosystemic shunt. We have animal data, US guided gene therapy. But what is the biggest hurdle? Because it is also very important. You can't keep on praising about the one modality, you should know the hurdles. Regarding the liver biopsy, you require a sedation, that's number one. And the cost, it is little costlier than percutaneous. Vascular intervention, ability during the emergency, and the cost. US guided portal pressure gradient, I think sedation sometimes affect the portal pressure gradient. The standardization of the technique is required. And the one of the major late limiting step, which I feel, is availability of expertise and the infrastructure. What you require to train more and more people for the endoscopic ultrasound. You create more infrastructure so you can get the better studies and to get the better knowledge about the US guided endohepatology. Cost concern, I think, can be made broader application with the wider availability. Cost can come down. I always feel endohepatology is the one-stop shop for diagnosis and therapeutic potential. Liver biopsy, liver lesion and the anatomy, I think it is very well feasible and very good literature available. Regarding US-guided liver biopsy, we are going from good to the better to the best. Endoscopy, gastric varices measurement, I think it is moving from endoscopist to the endosonologist. For PPG, we are still in infancy. But what we require an expertise in the EUS and the basic technique to learn the FNB and cyst drainage before embarking on endohepatology. Technical staff training and optimal backup is important. Decentralization of expertise, as I said, train more people is going to benefit the new modality. Better standardization techniques are important. In last, I would like to say, because when I talk this topic in the hepatology forum, so many hand raised for the questions. But I always say, I started my line, 2000, the big surgeon give the big incision. 2023, we are doing the endoscopic surgery. We are going from open surgery to the laparoscopic surgery to the single port surgery to endoscopic surgery. So progress is not one big change, but it is a series of small steps. Thank you for patience hearing. And I think this is one of the very important platform. As a secretary to SGI, I'm organizing the EndoCon 2024 in April 2024, 19 to 21st. Those who are keen, I welcome you all. Please do attend. This will be a fantastic course, both for hands-on training, for postgraduate, for didactic lectures, for state-of-the-art lectures, and we will have 15 hours of live endoscopic stream, and we are planning to demonstrate from Brazil and from the US also for one hour. So 15 hours of live streaming from the Asian, European, and American, as well as Indian stars at Medanta Medicity, as well as the live demonstration outside the country. We will try, but yes, this will be a fantastic 3 days scientific, dedicated endoscopic program, and I invite you all, and please do come. Anything required for this, please connect to Professor Baiju. I'm in touch with him, and I will be very happy to host you to New Delhi for this conference. Thank you for the patience hearing.
Thank you, Dr. Rajesh Puri, for the wonderful talk as expected. We can feel the passion of teaching in you. I hand over the mic to Dr. Asadur for the proceedings.
Thank you very much, Dr. Baiju. Beautiful talk, Dr. Puri. As Dr. Baiju said, you show us your passion and love for all what you are doing, and it's great all the improvements in these techniques that for sure will help patients all around the world in the way that these become more available and we can count more on these techniques. We have several questions. I don't know if we are going to have time for every one of those, but I will start in the order that they appear. First one says, is a question about the fine needle biopsy for hepatic biopsy. And it says if all hepatic segments or some are not available. If all are, you can reach every segment or some are not available.
Yeah. Is it accessible in all segments?
Yeah, I think it's a very good question. So definitely not all segments. It is difficult for us to puncture the segment 5 and 6. We can very well puncture the segment 1, 2, and 3, segment 7 and 8. So the right posterior lobe and the left lobe can be targeted very well. Those lesions, hepatic SOLs, who are situated in the right anterior segment, we cannot puncture.
Okay, so we continue. This question, you say something during the talk. Question said, if we are using glue N-octyl without lipiodol, in barracks, should we wait for 15-20 seconds before withdrawing needle to prevent risk of bleeding on needle withdrawal?
So the question was, if we are not using lipid oil.
Okay. If
No,
when then before
do you
we
wait
try
for 20 seconds?
So generally, you can wait very well. The question may come, the needle can stuck inside. Generally, in the clinical practice, as I said, I have done more than 100 cases, that situation doesn't arise. Even if you withdraw the needle very fast, is not a problem because you have already injected the coil and glue, and which is solidify within 15 seconds, as I said. So you can wait for 15 seconds, yes. But even if you are not waiting, you may have a small amount of ooze at the site of puncture. Otherwise, if you wait for 15
why
seconds...
it is not available in India?
The companies are not making, the companies are making is an N-butyl cyanoacrylate. N-octyl cyanoacrylate is not available.
Next question. Is there a cost comparison between endoscopic glue injection and EOS guided glue injection for these GI bleeding patients? And is it the main constraint in Indian scenario?
Yeah, I think it's a very good question, a very good question and very pertinent. Yes, there's a cost analysis, and it has shown that EOS guided coil and glue is cost effective or is same because those patients where you do endoscopy glue injection, the one-time cost for the first procedure, the EOS coil and glue is costly, but the patient when comes for the rebleeding, it increases the cost of treatment. So there are 1 or 2 studies available where the cost comparison was done on the long-term basis, and that shows that EOS coil and glue is as same cost as the endoscopic glue. But first-time cost of endoscopic glue is much cheaper than the EOS guided coil and glue.
Thank you. Next one. Do you always repeat endoscopy after EOS glue injection, or you repeat based on symptoms or hemoglobin?
So I don't repeat in my day-to-day practice because on table, you see the complete obliteration of the varix. There is no need to do an upper GI endoscopy. And I don't do even on the same time as well as later. because you have achieved the complete obliteration of the varix. Even if you want to assess, then endoscopy is not the good method, because endoscopy can only look for the intramucosal varix. If you want to see, better to do the CT angio or better to do a repeat endoscopic ultrasound to look for the patency of the either the remaining varix or the same varix.
Okay, perfect. Thank you.
Those who wanted to ask questions directly, they can raise your hand. I will unmute you. You can directly ask the questions to the speaker. This is only one forum in the webinar series where the participants also can ask questions directly to the speaker.
Okay, next one, the site for taking the optimal liver biopsy when you perform via ultrasound.
Yeah, so I think this is another very good question. The best site for the liver biopsy is you focus the left lobe and see the middle hepatic veins separating the segment 2 and 3. And if you just do a little clockwise, you will find 6 to 7 centimeter long segment of the avascular plane. So the left lobe, you will find a very good. If you want to puncture the right lobe, go to the first part of the duodenum and see the right lobe of the liver and then do the puncture.
Beautiful. And any advice for transplanted liver biopsy?
Yeah, so again, the very good question. Definitely you can do the, in the transplant liver, you can do the US guided liver biopsy. That is possible. We have done a couple of cases because my center is actively doing the liver transplant. So few cases of the liver biopsy we have performed with the US guided.
Well, there are a lot of audience that is congratulating you for your talk and for your messages and for your tips in all this technique, and I adhere obviously to these mentions. I would like to ask you something. What you will advise to any young endoscopist that wants to get involved in this technique? What will be your advice for them?
Yeah, I think a very good question, Professor. So first of all, as I mentioned in my talk also, you should be a very good endosonologist. You should be proficient of doing the US guided liver, US guided FNA or FNB, and the drainage procedure. That indicate that you are good, skillful doctors before embarking on the US guided vascular therapy or the US guided liver biopsy. That's number one. Number second, is very important before doing the US guided vascular therapy or liver biopsy. Please talk to your technician, your partner about the steps of the procedure. Do a rehearsal outside the patients because this is a difficult procedure. This is a life-saving procedure of the patient who is bleeding. If your technician is also not well versed with the procedure, he can goof up. A very simple example I will tell you. Many of the time, the technician forget to inject the 5% dextrose or the distal water and lot of air come and that obscure your vision. Then it's very difficult sometimes. Or you have taken the very good liver piece and he reintroduced the stylet to expel the specimen and the entire specimen break down. So discussion with the technician, teaching the steps of the procedure, guiding him the intra-procedure and the post-procedure steps, and always discuss with your hepatologist also or your pathologist that you have done the US guided liver biopsy, it is not. So these are the few things, and you should be proficient in US guided FNB procedure before embarking on the vascular therapy. And the exact size of the coils, exact material, 19G needle, everything should be available before doing the procedure.
The question
Excellent.
left in the chat box, that is, how to take portal vein thrombosis biopsy.
Yeah, very good. Portal venous sampling biopsy, especially the patient who has SCC, and you want to see that portal vein thrombus is a bland or this. So that is possible. And you have to see which site of the portal vein is blocked. You have two options. Either you do from the G junction or you do from the first part of the duodenum. And when the portal vein is thrombosed, generally it don't create any problem. But in my practice, I generally use the 25G needle. My first pass is without suction. If I don't get the good material, then I apply only 5 cc of suction. So few important things: go through the liver, puncture the portal vein, use the thin needle. Before puncturing and after puncturing, make sure that you apply the Doppler and use the thin needle. These are the few points while taking the portal venous sampling from the portal venous thrombus.
There are some other not questions but requests about bibliography, some books to read, some information to get education in this area. So maybe it will be nice, Dr. Puri, if you can send some reference, and then Dr. Baiju send via the chat, the WhatsApp.
So within 48 hours, I will send the very good articles on endohepatology. When you read, it is going to help you.
Yeah,
Perfect.
you can
One
send to
thing-
me. I'll be sharing it with the groups.
And one thing was, I think I was a little bit confused. I was initially thinking to do a live demonstration of all these cases. I prepared also, and few days before I come to know I have to give the lecture only. Otherwise, I would have shown in the real time the live
Yeah.
demonstration of all
The thing
three.
is that actually we don't know how many of the audience is interested in watching it live.
Yeah.
And it's all depends on their interest only. We will plan a live program later after seeing the interest of the audience.
I will send the article, sir, to you tomorrow. Most likely, I will send you the good articles, and people can read it, and that is going to help them.
So today there was no direct questions to the speaker. This is an excellent opportunity to ask the questions directly to the speaker.
Okay. Okay. Well,
Yeah.
we have no more questions. The audience send the emails in order to get more information, but we have no more questions. So again, the lecture was superb, amazing to listen to you, Dr. Puri. So I don't know if you want to close, Dr. Baiju.
Yeah. Thank you, Dr. Rajesh Puri, for the wonderful lecture and beautiful demonstration of the procedures. And thank you, Dr. ASADUR. We are really honored to have you here. We invite another lecture from you in the near future. So thank you all for joining. Thank you, Dr. Anhar, for introducing the speaker and moderator. This the talk will be available in the YouTube channel of Senadhipan Education Foundation. Those who wanted to take the certificates for attendance, please write to me, senadhipan@gmail.com within 2 days. After 2 days, we will not entertain because that will be closed. So any queries you can write to me. I'll be answering to Dr. Rajesh Puri regarding this topic. So thank you one and all for joining. We will end the webinar now. Thank you once again.
Thank you, Professor Baiju. Thank you, Dr. ASADUR,
Thank you so much.
this opportunity. And really, I was very happy to deliver a lecture, and will be very happy to deliver in the future also.
Amazing.
Thank you.
Thank you.
Thank you.